Welcome to the JIPO author interview series. Today we're hosting Dr. Torres. He's the author of Management of Hepatitis B virus and Hepatitis C virus infections in patients with cancer receiving immune checkpoint inhibitors. Dr. Harrys Torres is a professor in the Department of Infectious Disease, Infection Control, and Employee Health at the University of Texas MD Anderson Cancer Center in Houston. Welcome, Dr. Torres. How are you doing?
Fine. Thank you for inviting me, Dr. Zarfia. It's a very exciting opportunity to share with all of you what we have found and published in this very prestigious journal. Thank you for inviting me.
Yeah, thank you for having the time. Let's start off with the overview of the current understanding of immune checkpoint inhibitors' impact on cancer patients with Hepatitis B virus and Hepatitis C virus infections. What's our current understanding of the mechanism of actions of immune checkpoint inhibitors? And what are the challenges in managing those patients with those infections in cancer patients who are receiving immune checkpoint inhibitors?
It's a very exciting and very complicated question. And by the way, and I'm going to focus my answer from the infectious standpoint, which is, the subject of the review is how checkpoint inhibitors can affect these two infections. These are two chronic infections, and what we know, this hepatitis B and hepatitis C, they have been associated with T cell exhaustion, specifically virus-specific CD8 T cell exhaustion. So what is very interesting on the immune checkpoint inhibitors is they can reverse that. So the mechanism is different from cancer, but from the infectious standpoint, this exhaustion can be reversed by the immune checkpoint inhibitors, and they can actually even inhibit these viruses. So that's why you have seen reports of inhibition of hepatitis B and hepatitis C infections on patients receiving checkpoint inhibitors. However, in this article, we elaborate on more details and even some potential side effects that can be associated with reactivation of hepatitis B and hepatitis C. The jury is still out. We don't know mechanistically how this happened, but we know that there are some reports out there showing both spectrums of the disease, reactivation of these chronic infections, but also inhibition and even cure of this infection using checkpoint inhibitors. How this impact the patient care? And it's a very interesting question on how can we approach this from the management standpoint. And let's start with hepatitis B infection. So we found in the article that the reactivation rate of hepatitis B is very low. It's about approximately 2%. And it's a little bit higher in patients who have chronic infection, meaning those who have surface antigen positive. It may be a little bit around 2%, but it can be as low as 0.3% on patients who have past infection. So that is the first important message there. If the patient have chronic infection, yes, this patient is at risk for reactivation. So the recommendation is to start prophylaxis for hepatitis B reactivation on this patient. If the patient is coming to you and the patient have a surface antigen positive or DNA positive, yes, please start this patient on hepatitis B treatment. With any of the hepatitis B treatment approved in the US. So we have entecavir, we have two formulations of tenofovir. Either one, any of those three ones can be used. So then if the patient has past infection, meaning that the patient has only core positive antibody with everything else negative. So there is no active replication of the virus. It's only an exposure. These patients can be safely monitored without antiviral treatment. And safely monitor what we typically do in our institution. We monitor the ALT periodically, the alanine aminotransferase periodically, and it's being monitored every 2 to 8 weeks. And if we see any unexplained elevation of the ALT, we check for the DNA. And we also see these patients every 3 months in our clinic with hepatitis B DNA and hepatitis B surface antigen. That's how we monitor those patients. If we see an and any evidence of viral reactivation, then we start those patients on antiviral therapy right away, called preemptive therapy. So for patients with chronic hepatitis B, yes, we recommend to start before starting with immune checkpoint inhibitors with prophylaxis. For patients with past hepatitis B or resolved hepatitis B, monitor those patients without prophylaxis. That's for hepatitis B. And always remember, this may even be beneficial for the patient, the use of checkpoint inhibitors of hepatitis B. There are even clinical trials right now exploring how the use of immune checkpoint inhibitors can help achieving cure of hepatitis B in non-cancer patients. So it's really fascinating how these molecules can help not only in the oncologic field, but also in the infectious diseases field. For hepatitis C, yeah, and for hepatitis C, it's slightly different. Is we don't have two spectrums of the diseases. So we don't have a pass or active. We simply have active hepatitis C, and those are patients who are chronically infected for more than 3 months. So what is the impact of immune checkpoint inhibitors? Yes, it can be associated with reactivation, and we have seen that in prospective studies. We have seen that on patients who are on immunosuppressive therapy related to toxicity of checkpoint inhibitors. If the patient is receiving checkpoint inhibitors without any side effect that requires immunosuppression, like infliximab or high-dose steroids or any of the immunosuppressants, then those patients can simply be monitored, and the hepatitis C can be treated later on. It's safe. So we have seen that prospectively in our studies. If the patient is developing some type of toxicity, and then you see the viral load of hepatitis C increasing above the normal variation, which is typically 1 log, and you can read on the article how we define reactivation of hepatitis C, as well as how we define reactivation of hepatitis B. And then you can see there that the rate is very low of reactivation of hepatitis C. We typically recommend those patients to proceed with cancer treatment as needed, and we monitor them in clinic. Once they have received checkpoint inhibitors, and this is applicable to hepatitis C, and that's what we do routinely. So when the patient has received hepatitis checkpoint inhibitors, most of the time this patient stayed on this therapy for several months, years sometimes. So when that is the case, then we simultaneously treat with checkpoint inhibitors and what we call direct acting antivirals. Those are the medications used to treat hepatitis C. So we can simultaneously use both immune checkpoint inhibitors and hepatitis C treatment. But it is not an emergency to treat those patients for hepatitis C right away. So they can start the immunotherapy, and then down the road, a few months after, we start the treatment for hepatitis C.
So what trends have you observed in the incidence or severity of hepatitis B virus or hepatitis C virus reactivation in patients undergoing immunotherapy, where they the activation and the incidence were, and the reactivation led to a severe disease of the infection, or that was similar to the other patient population? And what considerations do we need to take into account when treating hepatitis B virus and hepatitis C virus infection in these patients, in our patient population, cancer patients specifically, who are receiving immunotherapy?
7 questions on the trends. Let's start with the trends. What I have seen is, before, we didn't have enough information on how to approach this. And I remember in the past using prophylaxis for everyone. There was a concern that this patient may reactivate hepatitis B or hepatitis C. So there was a lot of misinformation on that. So now we know that these patients can be monitored if they have past hepatitis B and needs treatment if they do have active hepatitis B. So the trend is a beneficial trend in terms of now we are monitoring the patient. We know more, we have more safety data, and we're also enrolling these patients on clinical trials. So we are typically telling the teams, so our oncologists here, if you need to enroll this patient on a clinical trial, proceed, and we will monitor the patients. If the infection is active, we will give the patient the appropriate therapy. If the infection is not active, it's only a pass or result, we will monitor. So that is a victory, if we can say it in that way, because in the past, some of these patients were even excluded from clinical trials because we didn't know what to do. Now it's not the case. So we allow the patients to proceed with clinical trials. And the same for hepatitis C. In the past, hepatitis C was considered an exclusion criterion for clinical trials, in cancer clinical trials. So we have demonstrated that should not be the case anymore. So these patients can be enrolled in clinical trials, and the hepatitis C will be addressed later on. So we try as much as we can not to do the hepatitis C treatment and cancer treatment at the same time, because the patient may develop some toxicity. And to avoid overlapping toxicities, we prefer the patient to go first with immunotherapy, and then we add the direct acting antivirals later on. And potential drug-drug interactions. We haven't seen that at this point, but it's always a concern. That's why we try to go with one intervention first and then the second intervention. That's for hepatitis C.
Nice. That's really interesting. So what further research or clinical trials do you believe are needed to advance our understanding of managing hepatitis B virus or hepatitis C virus infection in cancer patients undergoing immune checkpoint inhibitors? Do we need to do further research or further clinical trials in order to have a better understanding of how to manage those patient populations?
That's a very good question. It's actually a very complicated one because unfortunately, most of the data we have right now is based on retrospective studies or case series or even case reports. So we need more prospective data on this patients with hepatitis B or hepatitis C. We also need to enroll patients on clinical trials and see how they do based on the different clinical trials they're receiving. Patient combining chemotherapy and immunotherapy, see what's happened to the chronic infections. We also need to find out more about the benefits of these antineoplastic agents, because they can be beneficial. They can even cure the infection. So we reported recently, and a different journal, so we published data of the case of one patient who cured hepatitis C, completely cured by simply using checkpoint inhibitors. And so it can happen. And as I said before, that's been explored on clinical trials in non-cancer patients to cure hepatitis B. I think that we still need more research, more prospective data, well-randomized studies on the oncologic benefits of using this, but also on the virologic benefits of using it. Because so we're boosting the immune response on this patient. We're improving the T-cell response. So we simply can reduce the replication of these viruses by using checkpoint inhibition. So it's a very exciting opportunity, and many studies can be coming from here.
My final questions, actually, Dr. Torres, are there any specific recommendations or guidelines that you recommend and emphasize for clinicians who are managing patients with Hep B and Hep C infections who are also receiving immune checkpoint inhibitors for cancer treatment?
Thank you for the question. Actually, that is the beauty of this article. Because this article, when people invited us to write this article, because there is nothing out there in terms of formal recommendations. So there are no professional societies making strong recommendations yet. That was the relevance of this article that you can access on the website of the journal and look that up. So, but what we recommend is patients who have passed hepatitis B, screen those patients for hepatitis B with 3 markers: hepatitis B surface antibody, hepatitis B surface antigen, hepatitis B core antibody. Obtain the 3. If the patient has evidence of active hepatitis B, meaning surface antigen positive with core positive, and start those patients on antiviral therapy and proceed with immunotherapy. If the patient have only core positive with a negative surface antigen or negative surface antibody, no need to start antiviral therapy. Proceed with the checkpoint inhibitor, and then the patient should be monitored without antiviral therapy. And that is an important message. So regardless of what result is coming positive, the immunotherapy can be given. There is no reason not to give immunotherapy to these patients. So that is for the hepatitis B. For the hepatitis C, it's even more simple. Proceed. There is only one test that you're going to get, which is the hepatitis C antibody. And you do the confirmatory test with the hepatitis C RNA. If the RNA is positive, the patient is chronically infected, proceed with immunotherapy, and that can be monitored and treated later on. Typically, we treat these patients at least 3 to 6 months after they are on cancer treatment. So to allow the patient to tolerate the first intervention before we add new medications. But the message is proceed with immunotherapy. It is safe on patients receiving checkpoint inhibitors. Simply take a look at the article and you're going to see some more formal recommendations, some details, but I have summarized what we typically tell our oncologists here.
That's really interesting. Thank you so much for all these valuable recommendations and valuable notes. And I would invite everyone from our audience to go ahead and download this article because it's really interesting and worth reading. And it's really well written and really, I was engaged when I was reading the articles.
Thank you, Dr. Zarfia, and everyone at the journal for inviting us and giving us this opportunity. And I know many people will benefit from these results. Thank you.
Thank you.